So we are live now. Delegates can hear us.
Okay. Okay, let me start sharing my screen. Good evening, everybody, and welcome to this fourth and the last webinar in the series of these four webinars that we had organized for patients of Parkinson's disease and caregivers. We had an overwhelming success in these webinars. There have been huge number of people who have registered for this webinars. Some of you have been able to attend, some of you have missed out a couple of ones. So whosoever have missed out, they will be able to have an access to this webinar later on. We are going to upload the recordings. And if you become a member of the Parkinson Care Trust, you should be able to get an access to this webinar. You would find the link to becoming a member towards the end of the presentation. I will remind you. At that time, you can take a snapshot of that. So let me give you a little bit brief background about what is Parkinson Care Trust and what do we do during this in this Parkinson Care Trust. Basically, it's a small Parkinson patients organized trust which is run out of Jaslok Hospital campus. And every year we do this kind of Parkinson's patients related activity starting from March onwards because in April it is we celebrate World Parkinson's Day. Here you can see that one of the most common activities or consistent activities that we have been performing is a Parkinson's care diagnostic camp where we examine the patients. The difference of this camp is that each patient is examined by a consultant, so all patients get due attention, and it's not a camp where people can just walk in. They have to register, and hence they have been properly seen in an organized fashion. We also organize several webinar series. Before this, we used to meet physically, and you can see one of such events where we have patients talking about their experience, which helps you to be motivated. We have people who are active in the field talking about it. We bring in some medical experts to highlight newer developments in the field of Parkinson's disease, and that helps all patients and caregivers to get updated on the current scene of Parkinson's disease. The Parkinson Care Trust also offers some financial support to patients, especially patients who have undergone deep brain stimulation and they have had difficulty in replacing their pacemaker. Those patients, they are assisted with the help of small financial aid. As I said, this is a newly formed trust growing in size. So this trust does help that. We want to create a large network of Parkinson's disease patients who can then communicate amongst themselves and exchange ideas, monitored by some people who are active in the field so that unwanted or wrong informations are not passed on. Offer regular updates on various aspects of research because Parkinson's disease is a very fast evolving branch and a lot of research is happening in this field. So you want to be current with the research and also aware about what is correct research and what is wrong research. Provide enhanced support and guidance to Parkinson's disease patients and caregivers. We understand the importance of the caregivers a lot. So the second webinar in this series was actually entirely focused on caregivers. So it is very important for people to understand that caregivers play a very important role in making the quality of life better for Parkinson's disease patient. And then various other activities we will be bringing updates to you. So this is the URL. You can just take a picture on your mobile phone or a screenshot if you are using joined on a mobile, so that you can then, it's a very short URL. You can join this trust. It's a small form that you fill in so that you can get all the updates and you can be connected for regular activity. There are no fees for joining this. It is completely free of charge. So this is a snapshot of our first webinar where we talked about how to improve quality of life for patients of Parkinson's disease. And this was a very focused webinar, basically only focusing on important aspects that we find have patients of Parkinson's disease have questions about, like what diet to take, how to fight the constipation, how to fight frequent urination. So those are the things. What are the type of other activities that the patient can take? What are the things that can enhance the overall quality of life? Things like that. One of the discussion points was music therapies and dancing therapy and other therapy hobbies of Parkinson's disease. So all these things were discussed. In the second webinar, which was directly aimed at improving some of the problems that the patients of Parkinson's disease patient face, especially speech and things like that. And here we had a speech therapist, we had a physiotherapist who showed certain important tricks for balancing and walking. And then we had our own expert anesthesiologist. She has been teaching meditation for past 15 years as a hobby. And she joined us and she then showed how improved quality of life can be obtained for the caregivers and for the patients. And here you can see all the patients who had participated along with the caregivers doing meditation. The third webinar was based on conquering Parkinson disease, and that this webinar was a great success. We had real life stories from various patients of Parkinson's disease who experienced their disease and how they combated their disease and how they overcome their disease. These are the patients who have been suffering, who are still suffering from Parkinson's disease, but they have not got the disease better of them. For example, here we have one doctor called Dr. Kakkar. He has been suffering from Parkinson's disease for 19 years. He is a veteran from the army, and he attended the webinar and gave a lecture in the webinar after coming out of a very serious illness and hospitalization only 3 days back. So this is the kind of inspiration these patients gave and provided to the other people who attended this meeting. And we are now on to the fourth webinar, and today we are going to focus only on the medical and surgical updates on Parkinson's disease, and we have excellent speakers with us. We have Dr. Paresh Doshi. He's a movement disorder specialist working at Jaslok Hospital and a friend and colleague of mine. And we have Dr. Wei Hu, who is joining us from Florida. He is also from a renowned center, and he is also interested and focused on movement disorder specialist and working a lot in the field of Parkinson's disease and movement disorders. So today we will be having 4 lectures, one after the other. Dr. Wei, who will be talking on the medical management. Dr. Paresh Doshi will talk on very important non-motor symptoms of Parkinson's disease. You may not know the word non-motor, but when you hear about those symptoms which Dr. Doshi is going to talk, you will relate that, yes, oh, you also suffer from this and you might want to benefit from this. I shall be talking about deep brain stimulation and its updates. And the last would be for patients who have already undergone deep brain stimulation, we would be talking about do's and don'ts. So with that, I would like to start the webinar, and I would like to invite Dr. Wei Hu to join us and deliver his lecture.
Professor Doshi, for your great organization, and also thank you, Dr. Wadia, for participating in this meeting. And thank you, Professor Doshi, for inviting me to present our work on the movement disorder, particularly Parkinson's disease management. I'm sharing the video now. I think it works. Yeah. So I'm from University of Florida, mainly working on the clinical and research for the Parkinson's disease diagnosis and management. So today I just give you an update on the Parkinson's disease treatment, mainly focus on the motor symptoms, and also would briefly introduce our center to you. So as you already know, Parkinson's disease is a common neurological disorder and affected the older patients, particularly the people older than 65 years old. Patients will develop a rigidity, tremor, gait problem due to the dopamine loss in the brain. And as you can see, the majority of the patients were located in North America and Asia, including India and China. So this disease is more and more common because of the societies are getting old in the world, particularly in the USA and Asia country. And University of Florida established the Movement Disorder Center back to 2002 and had almost 2 decades history of the management and diagnosis of Parkinson's disease. So this is our leadership in our institute. So Dr. Michael Okun is a very well-known movement disorder doctor, particularly for Parkinson's disease. And he is also a clinical and a research scientist for the Parkinson's disease treatment, particularly for neuromodulation treatment. And Dr. Brian Hong is the chair and the professor of the neurosurgery department, mainly focused on the tumor and brain vascular disorder. So Dr. Lavoie was just moved from Harvard to University of Florida, and he is the associate chair of our institute and department, focused on the Parkinson's disease and the neurodegenerative disease research. He is also the chief editor of the Brain Research. And Dr. David Vaillancourt is the chair for the motor function department at our institute. And he is long history of the Parkinson's disease diagnosis research, particularly for the brain MRI imaging and AI technology in the diagnosis of the Parkinson's disease, Parkinsonism. So since our institute established in 2002, and after 10 years development, in 2012, we are one of the best center in the United States. And Dr. Okun and his group and our kind of clinician and scientists published several papers in internationally well-known journal, including New England Journal of Medicine, JAMA, Lancet Neurology, as well as Nature Review on Neurology. So this paper mainly focuses on the diagnosis and the management of the Parkinson's disease. As you can see, this is the map of the American University Hospital and well-known university hospital. Florida is located in the south west, and relatively most of institute are located in East Coast and West Coast. And it's pretty competitive here to become the well-known, one of the top women disorder center in the United States, and particularly in Florida, like Mayo Clinic, Cleveland, MD Anderson, Mount Sinai, all the well-known institute had a hospital here. So University of Florida had a collaboration and also competition with all these well-known institute. So this is the map of the Florida. Florida is well known for retired population residents. So a lot of retired people come over here. Therefore, the incidence prevalence of Parkinson's disease is relatively higher than the other states. So thanks for the great gift of Mr. Fixel family. So in 2018, they donate the patient. This is Mr. Fixel's father. He got the Parkinson's disease and got treatment at our center. Then he generously donated $20 million to our center for movement disorder and neurodegenerative disease clinical research. And University of Florida matched this donation. So totally we got a $40 million donation to establish a new institute called the Fixel Institute, which is established in 2019 and mainly focus on the various neurodegenerative disorder like Parkinson's disease and Alzheimer's disease as well. So Dr. Okun is a neurologist for Parkinson, while Dr. Foote is a neurosurgeon for Parkinson's disease. And so we hope this foundation can help us recruit a more well-known professor all over the world and develop a new treatment for this disease.
Dr. Hu, can you speak up a little bit because the sound on this side is coming a little soft? Yeah.
Oh, okay, sorry.
Yeah. Now it is
The
correct.
audio is
Yeah.
not-
It's better
yeah,
now. Yeah. Correct.
thank you.
Thank
So
you.
now I'm introduce some Parkinson disease. This is all well-known motor symptoms and non-motor symptoms. I believe Dr. Wadia will be spend more time on the non-motor symptoms. So the patients will be bothered by slow movements, resting tremor, gait problem, and also non-motor symptoms, particularly autonomic dysfunction, sleep dysfunction, autonomic dysfunction including like constipation, blood pressure fluctuation, and particularly the depression, anxiety, which make patients and his family very frustrated and sometimes difficult to management. So I'm going to focus on the motor symptoms. So this is the figure from the our JAMA paper from Dr. Okum in 2020. So we think it's important to characterize the subtypes of the Parkinson disease. So here's the suggestion. Patients can be characterized and subgrouped by three kind of subtypes. The majority of patients are mild to intermediate motor predominant symptoms. And fortunately, as many as 80% of patients had a good medication and slow disease progression, slow to moderate disease progression. Unfortunately, around 10% of the patients will have severe disease symptoms with rapid disease progression. And these patients may resistant to dopamine medication and the treatment. But it should be emphasized that majority of patients can be a good response to the medication treatment. And so I believe carbidopa, levodopa, or Sinemet is very commonly used, or Medopa, very commonly used in any country, including Asia and North America. So in the early stage disease, patients usually takes medication every 3 to 4 hours. And with progress, so they may need the more often, like 2 hours. So this is on and off time, the cause motor fluctuation. So our doctor and the research scientists are focusing on the off medication off period, and to try to help these patients. And over time, some patients will develop called dyskinesia, one kind of involuntary movements. And this is also bothersome for the patients and his family member, his or her family member. So I'm going to introduce the treatment. And so all these treatment are available in all over the world. And medication is play a important role in the disease treatment, particularly during the early stage and the middle stage. Certainly, Professor Doshi gonna focus on this of this treatment. And so this is a figure table from our center back in 2020. And so here's the list of the medication. So as you can see, there's a lot of the medication available. And I characterized with, I would say, 4 group. But mainly one group is dopamine medication. So levodopa still the majority, the mainstay medication for the disease, and all the other medication like monoamine oxidase inhibitor and also the COMT inhibitor. They block enzymes that degrade the dopamine per the benefits of the levodopa. So levodopa is still the major treatment for the patients. And I would like to introduce some enteral suspicion carbidopa levodopa and inhaled levodopa. And as you know, the inhaled levodopa is levodopa inhalation powder, which I think FDA approved 2019 or the early of 2020. It's a new medication. It can be administered via an inhalation pump. The inhaler release the medication into the lungs without needing to be pressed or manipulating, coordinating with inhalation. And this medication can cross the blood-brain barrier, go to the brain very easily. So had a very fast, effective treatment, and can be used combined with the oral carbidopa levodopa. And sometimes patients had some activity, need the medication immediately to exert benefit shortly. So this is the good choice. And there's also called the Diopa therapy, is a form of carbidopa levodopa delivered in gel form called enteral suspension. Rather than a pill, it is used to treat the motor symptoms of Parkinson's disease. So you need to ask surgery to make like a hole in the stomach wall to place a tube in the intestine, and the pump then deliver the medication to your intestine, the digestive system, and then the medication can go to the brain to have a more kind of effective benefit. And this is another medication, not FDA approved, but it's on the clinical trial, phase 3 clinical trial in our center. It's a novel liquid formulation of carbidopa levodopa and can be used to continuous subcutaneous administered via infusion pump system. So this is particularly good for the patients who had a absorbable problem of the medication and or had either had a motor fluctuation or dyskinesia symptoms. And this pump is like an insulin pump placed on the skin, and you don't need to have any surgery. Then give you the medication continuous, slowly, equally dose all over the time, over the daytime and the week and a year. So this is very likely will be approved next year, which would be helpful for a lot of patients. And so this is a general approach to treating motor symptoms in Parkinson's disease, including all these medication drugs. And we also, as mentioned by Professor Doshi in the opening mark regarding the physical therapy, rehabilitation therapy, this is also very important, or sometimes more important than medication for managing the motor symptoms of Parkinson's disease. So the last, I would like to introduce our second opinion program, and our center is internationally well known, and Professor Okon and all the doctors can provide the online second opinion to diagnosis and management of all neurological disease and movement disorder. Thank you very much.
Thank you, Dr. Hu, and thanks for finishing well, absolutely under time. It was an excellent lecture, and we would be having some question answers in the end. Meanwhile, people can put their questions in the Q&A box, and whichever speaker it belongs to, will try to answer that during the course of this webinar. We now invite Dr. Petros Vadia. He's a movement disorder specialist, as I mentioned to you earlier, working at Jaslok Hospital. And he will share with us about the known motor symptoms and management of those symptoms in Parkinson's disease.
Yeah. Good evening, everybody, and Thank you, Dr. Doshi, for inviting me to give a talk. And thank you, Dr. Way, for an excellent talk and an insight into the challenges of the senior citizens of Florida. So as Dr. Way has already introduced, I'm going to be talking about management of non-motor symptoms. And, and I'll be showing you the non-motor symptoms, that is apart from the slowness of movement, tremor, and rigidity, which you all know. So if you look at the time course of Parkinson's disease, if this center line is where your Parkinson gets diagnosed, it usually gets diagnosed with the movement symptoms. So this is because it occurs when there is movement becomes slow, there is a tremor, and or there's a frozen shoulder, and then you go to the doctor diagnoses that Parkinson's disease. There are many symptoms which can predate Parkinson's as long as 20 years, including constipation, REM sleep behavior disorder, which is dream enactment behavior, where you're acting out your dreams. You can be punching your partner in your sleep. So this is REM sleep behavior disorder. You can have erectile dysfunction, hyposmia, that is lack of smell, and you can even have depression occurring a few years before the diagnosis of Parkinson's disease. So this entire line at the bottom are your non-motor symptoms, which is shown here. Apart from depression, smell issues, sleep issues, constipation, pain, fatigue, memory issues, so dementia can occur. You can have drop in blood pressure on standing, what we call orthostatic hypotension. You can develop urinary symptoms, and there can be a lot of neuropsychiatric symptoms like hallucinations. So this is what I will be focusing on today. The challenges are different at different stages of the disease. Before the diagnosis of the disease, you can have constipation, sleep issues, depression. After diagnosis, you can have initially pain, fatigue, a lot of anxiety, depression. Why me? Why did I get Parkinson's disease? Difficulty accepting the diagnosis. And later on, as the disease advances, you have the problems of advanced Parkinson's disease, where you develop urinary incontinence, drop in blood pressure on standing, memory issues, hallucinations, so psychosis as they call it. And these are the motor symptoms. And Dr. Y already talked to you about the on-off fluctuations, the dyskinesias that can occur in Parkinson's disease. So this is to summarize what I'll be talking about today. We'll be talking about autonomic symptoms, which basically include slowing of the bowel movements. Just like the limb movements slow down, the intestine also slows down, which causes constipation. You can get urinary symptoms. You can have difficulty controlling urine. You might know that you want to pass urine, but before you reach the toilet, a little bit might leak into the clothes. You can have sweating difficulties. It can be a very warm day, like in the Mumbai summer, but you could be sweating. You could be still wearing a muffler, a monkey cap, refusing to put on the fan, refusing to put on the AC. And it can be extremely disturbing to the partner. There can also be a drop in blood pressure on standing, which can cause fainting spells. The patient can lose consciousness on standing. There are a lot of neurobehavioral symptoms, which I'll be going through in a more detail, sleep issues and fatigue. So we'll go with the autonomic symptoms. The autonomic symptoms are mainly constipation. You can have nausea mainly, which is drug related. You can have genitourinary symptoms where you can have nocturia, that's passing excessive urine at night. Frequency of urine, urinary urgency, urgent continence, where you dribble before you reach the toilet, and you can have difficulties with erection in men. You can have drop in blood pressure on standing, and you can have excessive sweating. And this is just to tell you that constipation was recognized way back in 1817 in James Parkinson's essay, where he says the actions of the bowels are very much retarded, indicating that there is slowness of the intestinal movements. This is a gentleman who's 59-year-old, had constipation for 1 year. He was so bad that he required Peglac. Peglac is a product that we use for severe constipation in patients where we have to do a colonoscopy. It's a very, very severe laxative. And after 1 year, actually was the pickup of the movement symptoms of Parkinson's disease. So his constipation predated Parkinson's disease and was extremely severe. I've had patients who sit for about 12 hours a day in the loo because they can't pass stools, and they really need a lot of help. So constipation can be extremely distressing to the patient and the caregiver. So the lesson is constipation can predate Parkinson's, and it needs a lot of attention. Apart from constipation, you can have this phenomenon of drop in blood pressure on standing. It can be seen in up to 35% of the patients at 15 years of disease. The drop in BP can be because of the Parkinson medication itself drops blood pressure. Also, the disease drops blood pressure. And it can be a late feature of Parkinson's. If it occurs very early, you have to think of alternate diagnoses like MSA or dementia Lewy body. And when you treat this orthostatic hypotension, firstly, you have to stop all blood pressure medication if there are any. Sometimes you have to reduce the dopaminergic medication. There are ways to block the dopamine outside the brain. And we use domperidone to do that, or carbidopa also. You have to increase your fluid increase the sodium diet. Simple things like raising the head end of the bed, like in this diagram, using pressure stockings, abdominal binders. All of this can help in raising the blood pressure. And you have to frequently monitor the blood pressure lying down and standing. If you don't monitor the blood pressure standing, you'll never pick up this problem. And then suddenly you'll realize that the patient is fainting or losing consciousness. There are several drugs we can use like fludrocortisone, pyridostigmine, or midodrine to help this problem. So this is just the same slide again. We move on to the neurobehavioral symptoms, which can be extremely distressing for a caregiver. It could be anxiety, depression, apathy. You can have memory issues, dementia. You can have hallucinations, delusions, psychosis. And then you can have these unique symptoms called impulse control disorders, which I'll be explaining in a little bit. So anxiety can occur in about 40% of the patients. And it also often occurs with depression. You can get panic attacks where you can have heavy breathing. You can even lose consciousness during the panic attacks. You need a lot of counseling, reassurance, and drugs. Depression can occur in about 20 to 40% of the slowing. And many of the symptoms of depression, which are a lack of sleep, slowing of the mentation, difficulty concentration, are also symptoms of Parkinson's disease. So sometimes it is very difficult to tease out depression from Parkinson's disease. And you have to have a very high degree of suspicion for depression in patients with Parkinson's disease. You can even get suicidal, and unfortunately, after DBS, depression can worsen. So we are very, very careful to address all these issues in patients who are undergoing DBS. Depression can occur at various stages. It can occur prior to the diagnosis as a premotor symptom. It can occur at diagnosis, and at diagnosis is very difficult. Why did I get Parkinson's disease? What have I done wrong? And because we know Parkinson can occur to anybody, and it can occur due to genetic factors, environmental factors. So it can occur to anybody. So obviously the question of why me? Then later on, when you're doing very well with the medication, and then suddenly you start wearing off, like Dr. Way talked in his presentation, then you can get wearing off, and then you can get very depressed. I was doing so well, and now look at me, I cannot function, or there are times of day I can't function. And then you can get depression when the person is dependent on others for activities of daily living and said, I'm a burden on society, I'm a burden on another person. So at different stages, depression can occur. It's normal to have depression, but it's also normal to discuss it with your doctor and treat it, because we have excellent treatment. So not telling your doctor and not treating it is not helping anybody. It's not helping the patient nor the caregiver. So there are various things we can do to manage the depression. Even the dopaminergic drugs are antidepressants. So if you control the Parkinson better, depression itself reduces. And there are several classes of antidepressants which all can be used in Parkinson's disease. As far as memory in Parkinson's is concerned, James Parkinson in his initial report said the senses and intellect were unimpaired, but later on we realized that that's not true. In the Sydney multi-center study, where they've done 15 years follow-up of patients with Parkinson's disease, 48% had dementia and 36% had what is called as mild cognitive impairment, which often is considered a precursor to dementia. So almost 85% had some degree of memory impairment. So that's not small. But there is hope. This is a 72-year-old gentleman. I'd seen him with 8 years of Parkinson's disease. His wife said, you know, Daddy, he put his keys. He was looking around the whole house for it. He left his spectacles. He can't find them. Then the other day, he went to the wrong floor of the building. Can you imagine? He doesn't even remember the floor we live on. We're living in this house for the last 30 years. And then he started seeing things at night. He was seeing and telling me somebody's hitting him. I told him that's a curtain moving. Nobody's seeing you. And then we did his memory testing. His score was 22 out of 30, which is low. Normal is 26. We started him on a standard memory drug for Parkinson's disease called donepezil. 6 months later, the wife came, "Doctor, I can't thank you enough. I can't believe that's my same husband. His memory is good. He stopped seeing all these things and people. Now he actually sits with the grandchildren who I look after and he plays with them. And it's so much joy to see him playing with his grandchildren. He has enthusiasm. He devises games for them. And now she even has the confidence. She leaves him with the grandchildren at home, goes out, does her vegetable shopping, grocery shopping. So, and his memory scores did improve from 22 to 26. So although I'm saying that memory issues are common, unlike Alzheimer's disease, the Parkinson's disease dementia respond well to a class of drugs called cholinesterase inhibitors. Obviously, not everybody is as lucky as this gentleman was, but there is something that can be done. So important thing is, when you go for your visit, you must realize that all these symptoms that I'm telling you about are part of Parkinson's and they're not a separate problem. And you have to discuss it with your Parkinson doctor, with your neurologist or movement disorder specialist. If you don't discuss it, he's not going to be able to help you. So when you have cognitive impairment, we first confirm that there is a cognitive impairment. We do the memory test like we did. You look for vitamin deficiency. Vitamin deficiency causes memory symptoms. You look for thyroid issues. Sometimes there's a fall and there's a blood clot in the brain. So sometimes you have to do a CT scan. You look for a urine infection or you look for a chest infection. Currently, for those who have sudden onset memory symptoms, you have to look for COVID. COVID also does the same thing. So if you have an ongoing COVID infection, that can also do it. So you have to look for any infection, whether it's urine infection, chest infection, COVID. There are certain class of drugs that we use for Parkinson's disease, especially anticholinergics. In India, we use Pacitane, Benzex, Bexol, which are drugs which worsen memory. You have to stop these drugs which worsen memory. And then we have to use the class of drugs called rivastigmine or donepezil, which I described earlier, which can improve your memory. I'm going to go to another problem. This is a 67-year-old gentleman, Parkinson's since 9 years. He was having wearing off and dyskinesias like any other Parkinson's of that duration would be. But his main reason he had to be admitted to the hospital was he was seeing things. He was seeing there were people there. He was saying, "They're going to kill me. What are you doing? Call the cops, call the police." And it was impossible to control him. There was nobody in the house. The family tried explaining to them that there's nobody. Look, open the windows. There's nobody outside. But he was in this fixed belief. There were hallucinations. Now, there are a lot of drugs in his prescription which can worsen hallucinations. Amantadine, pramipexole, both can worsen hallucinations. So we had to do a major alteration of his prescription in the hospital. We added the same memory patch and we gave him quetiapine, which is an antipsychotic agent, and we were able to control his hallucinations. So hallucinations can occur in about 50 to 40% of treated Parkinson's disease. Visual hallucinations are the most common. Patients may or may not be aware of the Parkinson's disease. Delusions and paranoid behavior can occur in 5%. Early hallucinations may suggest dementia Lewy body. So hallucinations, in hallucinations, you can actually see human beings or animals or objects. This occurs more in dim light. They can last just for a few seconds or they can be persecutory and present all the time. Many times the patient have no awareness that they are not real. And he might say that they are there, I'm telling you they're there. And other times, in milder cases, the patients may know that they are not real and may be able to cope with them. The other most distressing part of the delusions, I've had situations where the patient has said that the spouse who is the caregiver, "Oh, you are going around with the driver or you're going around with somebody else." And this spouse infidelity is a big, big challenge. And can you imagine the distress the caregiver goes through when after 40 years of marriage, suddenly your spouse suspects that you're having an affair with somebody else? It is heart-wrenching. And in most conservative societies, the spouse is even embarrassed to discuss it with the doctor. So these are delusions of jealousy. You can have delusions of persecution. He's going to try and kill me. The spouse is poisoning me. So they will not even take medicines or food from the spouse or the caregiver. Then they can have delusions of abandonment. Nobody's looking after me. They're coming every day to look after you. But so all these are delusions and they require major alterations in your medicines. This is an example of visual illusions. Now, for an ordinary person, this looks just like a bush of flowers. For a person with visual illusions, you'll see that, oh, there are faces looking at me. Look, look, look. There are about 6 people looking at me. So these are delusions. So managing hallucinations, we have to first rule out infections, look for encephalopathy, look for constipation. Constipation can be a very, very common problem causing hallucinations. So you have to manage all these. You have to remove all those drugs which will worsen hallucinations. There are 3 drugs which are approved for treatment of hallucinations: quetiapine, clozapine. Clozapine is a great drug but requires blood monitoring, so you have to be very careful because your blood counts can fall. And pimavanserin, which we don't have in India, but I'm sure Dr. Y will tell us his experience. It's a great drug to control hallucinations, and it's approved for Parkinson's psychosis. Apart from this, there is also a role for using cholinesterase inhibitors, especially in those who have dementia. Just like we said, rivastigmine or donepezil earlier. I'm going to go to another very distressing neuropsychiatric problem, which is impulse control disorder. This is a 42-year-old diamond jeweler who was very well controlled on roperidol 12 milligrams per day. And then he started sleeping at 2 in the morning, waking up at 5 in the morning. And the moment I hear this, my ears are pricked. At night, he woke up, he would be awake whole night. He would open the refrigerator, eat a tub of ice cream at one shot, 4 liters of ice cream. He would be eating food. He'd spend his whole night doing carpentry. And when his wife said, "What did you make?" There's nothing to show because there's been no productive output from that carpentry. He would go online, go and shop carpentry equipment online, and busy spending money and wasting money on Amazon on things that he probably never understood what he was doing with anyway. This caused a lot of strained relations with his wife, and the wife almost said, "I'm ready for divorce." And the culprit was the dopamine agonist. Dopamine agonists that we have in India are pramipexole, roperidol, which are commonly available. Rotigotine patch we don't have in India at the moment, but these are drugs which can, apart from improving Parkinson's, also trigger what is called as the impulse control circuitry. So what this gentleman had was Parkinson. He had funding, he had compulsive shopping and binge eating, which are all known impulse control side effects. So impulse control disorders can include gambling. You can be spending hours at the slot machines or in the casino. You can be shopping for things that are really not essential to you. You can be just eating or binge eating. The most common impulse control disorder is hypersexuality, where people are searching the net for pornography. Funding is a repetitive behavior. So carpentry in this case was a funding. It's a repetitive behavior that has almost no productive output. And you can also get dopamine dysregulation syndrome, where people are popping extra medications beyond what is prescribed. As I told you, hypersexuality is one of the most earliest and the most well-recognized feature of Parkinson-related impulse control disorder. And the reason for all these impulse control disorders is that the circuitry, the dopamine circuitry, also works in the mesolimbic dopaminergic system, which is also the same circuitry that gives you reward behaviors. And if you get a reward from a slot machine, you're going on playing that whole day. And this is what has been found. And this is the reason why patients can get impulse control disorders. For this patient, we had to stop the roperidol. We had to substitute the roperidol with levodopa. It worsened his Parkinson's. Finally, we had to do DBN stimulation, but we were able to get rid of most of his impulse control issues. I'll move on to the last 2 sections of sleep and fatigue. So Parkinson patients can have difficulty falling asleep. They can have difficulty maintaining their sleep. And there are various drug adjustments we can do. The most common reason for them not able to sleep is that they are very stiff and slow at night, because most of the medications are given in the daytime. So we have to use control release preparations at night. And I'm going to show another slide on that. Another distressing symptom is REM sleep behavior disorder and excessive daytime sleepiness. I'm just going to show you a little bit. So this is akinesia or bradykinesia, which is affecting night sleep. And you can see that in the night, this lady has such a difficulty getting up. A normal person would just jump out of bed. This lady has like 6 steps to get out of bed. And she requires 6 steps to get out of the bed. And to treat this bradykinesia in bed, so difficulty in getting in bed, you often have to use controlled release preparation of levodopa, carbidopa. If you are lucky and you have access, you can use continuous dopaminergic stimulation, either in the form of long-acting dopamine agonists like roperidol or pramipexole long-release formulations, or you can use rotigotine patches, which unfortunately we don't have, or you can use apomorphine pump, which now we have access to, or you can use levodopa, carbidopa intestinal gel again, which we don't have access to at the moment. And of course, DBS really helps many of these symptoms. REM sleep behavior disorder is another distressing symptom. Basically, these people really are acting out their dreams and they believe that they're an actor in the dream. Normally, we all have dreams, but in the dreams, the body is stiff and unable to move. In Parkinson's, this stiffness gets reversed and the patient is able to move. So you can have and you can see that this gentleman is sleeping at night and suddenly he'll get up from his sleep and he's probably believing he's in an action movie and you can see in a minute he's going to get up from the sleep and look at him and he's getting up and he's imagining something and look at him punching away, and that's a dream. It's REM sleep behavior disorder. There are drugs for this. Clonazepam, melatonin are both there, and you can use environmental alterations using pillows, matting the bed from the spouse so that the spouse doesn't get injured. Another very distressing symptom of non-motor symptom is excessive daytime sleepiness. And it can be seen in up to 50% of Parkinson's patients versus 11% of the general population. You can have sudden sleep attacks, and 3.8% of the drivers in one survey said that they had sudden onset sleep. And you can imagine how distressing this is. And you can actually have road accidents. And the commonest cause is the dopamine agonist, the same drug that causes the impulse control disorders. And also the other reasons could be if you're not sleeping well at night, if you have all the sleep issues at night, you can fall asleep in the daytime. And Parkinson's itself in the elderly can cause excessive daytime sleepiness. So again, we have to get rid of the agonist, correct other sleep issues, and sometimes we have to use alerting agents like modafinil. Apart from all these issues, you can also have a lot of pain and sensory symptoms in Parkinson's disease. Many of these are actually really relieved if you control the Parkinson's better, or even DBS does that. Fatigue can be seen in about 35 to 58% of patients with Parkinson's disease. And various medications that will be tried, including antidepressants. One distressing symptom is non-motor fluctuation. Non-motor fluctuation is just like the motor symptoms fluctuate and you have on and off. You can have non-motor fluctuation. This is summer in Mumbai, May, which is like 35 to 40 degrees with 80-90% humidity. This is a gentleman in his off state. He's wearing a muffler, a monkey cap, socks, because he's so cold. He wouldn't let you put on the air conditioner. The whole city is sweating away. And this is him in the on state. Everything is out. The muffler is out. The monkey cap is out. The socks are up. This is a typical of non-motor fluctuations that you can see in Parkinson's disease. And non-motor fluctuations, just like motor fluctuations, respond to DBS. I'm not going to go over all this. So this is my last couple of slides. This is the Europar study, which is looking at subthalamic stimulation, that's deep brain stimulation, apomorphine pump, and levodopa-carbidopa intestinal infusion. And they looked at the improvement in non-motor symptoms. And they found that in all the situations, these are the non-motor symptoms before the intervention, after the intervention. And in most of these stars are showing significant improvement. So there was improvement in cardiovascular symptoms, sleep, mood, hallucinations, and each intervention had different domains which improved. So DBS improved sleep, mood, perceptual problems and hallucinations, urinary symptoms, sexual symptoms, and others. While on the other hand, apomorphine improved perceptual problems, attention, memory. Levodopa-carbidopa intestinal gel improved sleep, mood, gastrointestinal symptoms, indicating that even the non-motor symptoms are improved by all the advanced treatments that we have for Parkinson's disease. So I'd like to end my talk. It's a little exhaustive, but sorry. I'll end my talk by saying that it's important that you understand that symptoms as myriad and varied as constipation, shouting in sleep, memory issues, depression are all part of the same disease, that is Parkinson's disease. It's important that you raise the awareness of this with your neurologist so that they can give you medication and address these symptoms, because all these symptoms affect your quality of life severely, as hallucination. The last ray of hope is that with advanced therapies of Parkinson's, now we have increasing evidence. That paper which I showed you was as late as 2019, that these advanced treatments can actually improve the non-motor symptoms and improve the quality of life of Parkinson's patients. And just like Dr. Doshi said, there are physical therapies, occupational therapies, and cognitive therapies. And there are a lot of NGOs which are working in this field to make the lives of Parkinson patients better. This is one of them, Parkinson's Disease and Movement Disorder Society. And patients with Parkinson's disease describe their difficulties, can have decent quality of life. This is one of my Parkinson's disease patients who's a painter who's now finished almost 20 years of Parkinson's disease. But mind you, she's still painting. And these are some of the pictures of the paintings which she sent to me. So it's not that life ends with Parkinson's disease. And the goal of everybody, the patient, the caregiver, the treating physician, is to give as good a quality of life as possible with all the existing treatments and advances that we have for the patient hearing.
Thank you, Petros. It was an excellent narrative. And,
I think you're on mute, Paresh. I mean, we're not able to hear you.
I did unmute it. Is it okay? Now you are able to listen?
Yeah, we can hear you, sir.
Yeah. So that was an excellent narrative of non-motor symptoms with real life examples, which patients and we all can correlate with. And I'm sure a lot of patients would have found it very useful to understand that why they are having those problems which they thought that they may not be of Parkinson's disease. And second important message that you gave in your talk was the ray of hope, that those things which were thought earlier less manageable are now getting increasingly manageable if properly diagnosed and understood. I think with that, I would like to tell you and Dr. Hu both to answer some of the questions which may have come on the chat while I'm making my presentation. So now I will go on to my talk, and that talk is going to be on the surgical treatment for Parkinson's disease, what is new. So what we are going to quickly go through this, we go through the basic part of it, and then we go to the advanced part of the talk, which will share my thoughts on what new things are happening and what is going to happen on that. So let me start for novices. What is deep brain stimulation? Basically, it involves implantation of electrodes through a small hole on the top of the head, what we call a burr hole. Electrodes are implanted and connected to a pacemaker, and that pacemaker then delivers stimulation to the target area of the brain. And how do we do that? Before we go to that, let us understand what are the target areas of the brain that we refer to. There are three groups of cells, target cells, that we target in the patients of Parkinson's disease. But the two common ones are the subthalamic nucleus. It's a deeply located cell group, as you can see, way deep into the brain. And the second group is called globus pallidus internus. These are the two important target areas in the brain that we target for patients suffering from Parkinson's disease. And how do we control or modulate them? We can either do a lesion, where you can see here a lesion has been performed, or we can implant electrodes and do the stimulation. We will today focus mainly on deep brain stimulation because that is the most common therapy, and because of the shortage of time, we'll focus more on the stimulation. Deep brain stimulation therapy is a very complex procedure. It requires a large number of people who have been trained for several years and working as a team. Here you can see our team working together. We have any number of equipments that helps us to perform this. There's the navigation system, microelectrode recording machine. We have neurologist, neurosurgeon, anesthesiologist, everyone present in the OR to assist this in the surgery. To quickly take you through the surgical steps, because several patients have been asking what is the surgery like. This is a surgery performed under awake condition. It starts with the fixation of a stereotactic frame. This is followed by a CT scan, where patient is taken to the CT scan to locate the target. Once we have performed the CT scan, we take the patient into operation theater. So we have anatomically located the target. Now we want to physiologically locate the target. Physiologically means we want to find the signature of each cell. This is a recording from a single cell of patient's brain. It's called microelectrode recording. The patient is having tremor, and the cells in the brain will fire in synchronization with the tremors. You will see that in this same rhythm, you would see the cells firing on the microelectrode recording in a second. They coincide with the tremor, and this helps us to identify that we are in the right location, and we got the signature of the cell, as I call it. Then we want to see the improvement. You note that the patient is little better than the normal. Normally he would be slightly slower still, and there is stiffness in the hand. You can see the ratchet-like activity. The hand movements are not smooth. It is called cogwheeling. He is being tested for side effects. When we reach the target, there will be improvement in the rigidity. So there is an improvement in the rigidity. So this is how we locate, and then we implant the electrode in the patient's brain. We are putting the electrode in the patient's brain in the same spot where we had located the target. It is important that we go back to the same spot, and that we confirm by X-ray. So that is being confirmed on the X-ray. You can see the electrode there. We have reconfirmed that it has gone into the same place. So what are the indications for patients to undergo surgery for or DBS for Parkinson disease? Usually we do not advise deep brain stimulation for patients with disease duration less than 5 years. This is for two reasons. One is because till 5 to 7 years of disease, you can be very adequately and nicely managed with medication. So if you need surgery earlier than that, maybe you may not be suffering from Parkinson disease, but you may be suffering from some other disease which is rapidly progressing, and that may not be amenable to surgery. The second group of patients, which is the common indication for Parkinson disease, on-off fluctuation. Dr. Who explained to you on and off phenomena. When you take medicine, you get good power, that is on. When you lose the power of medicine, that is off. But then it starts fluctuating widely, and that is the time you want to take some help from surgical side. Significant dyskinesia. Dyskinesias are involuntary movement, dancing movement that the patient sees after taking levodopa, and that is after a few years of levodopa treatment. You start getting side effects of dopamine. Then there are off phase, increasing duration of off period where you get more rigidity, stiffness, and some patients do complain that this is also associated with curling of toes called dystonia or severe pain. And then uncontrolled tremors. Some of the patients ask me on this chat that is an uncontrolled tremor an indication for surgery? Most of the time, patients, Parkinson disease patients, tremors can be very well controlled with medication. 80%, 90% of the patients can be controlled with medical treatment. Only 10% of patients who have uncontrolled tremor may need deep brain stimulation. We have the similar kind of numbers in our total experience of surgery. So when the symptoms cannot be adequately controlled by medical management, one should try to seek surgical. This is patient before and after surgery. He has shuffling gait before surgery, and he is able to move freely. Bhavesh bhai, my video is playing properly?
Yes, sir.
Yeah, thank you. This is a patient much more advanced. You can see there is a marked amount of freezing, hardly able to take a step. She requires some support while standing also, barely able to take step. Stoop posture. Even she has to be moved from that freezing position with the help of some support and help. And the same patient after surgery, you can see that her hair is coming back. We do a complete head shave. So it is around 2 to 3 months after surgery. Her posture has improved, her walking has improved, everything has changed. So those were the beautiful videos that you can see and narrate, but you would also want to know what are the overall results and outcome of this surgery. Way early, we started operating or offering deep brain stimulation way back in 1998. So we initially examined our 30 patients and we found that we had around 60% improvement in the motor score. That is the disability scores of the patients at 2 years. And that score continued to improve, remain improved at 4 years. Similarly, we had around 37% reduction, 36% reduction in levodopa dose, which continued to remain sustained up to 38% at the end of 4 years. So basically, we have 35 to 40% reduction in dose and 60% improvement in off-period scores, which is a very good improvement over a period of time. We have had further improvements and much better outcome also as the learning curve increased, as which I will share with you later. I had several people asking me a couple of questions on early deep brain stimulation and deep brain stimulation in elderly. I'm 70-year-old. Can I be offered surgery? So we had our own analysis of that. We knew what we were doing, but we wanted to see what we had come out of with the results. So we had a comparative study of bilateral subthalamic deep brain stimulation in patients young versus old, coming out of Just Look Hospital. And what we found was we analyzed around, now we have 154 patients, but for that paper, we had 20 patients who had been analyzed. We have now 154 patients, out of which 143 have undergone STN-DBS and 11 have undergone GPI-DBS. This was the outcome of those patients that I told you, which have been published in the paper which I referred, and also in the movement disorder, that we had around similar level of improvement between young and old. So we had no difference in the clinical improvement profile of patients young and old. But yes, elderly patients require special care, special attention, special protocols. And that's why you see that we have offered certain patients GPI-DBS because in those patients we find that safety is important and maybe GPI-DBS might be helpful. Like this patient. This is a patient very elderly. You can see that he had a significant amount of disability. Total motor UPDRS score of 78 and 55. Hardly able to stand up. Very frail, very weak patient. The patient himself insisted that either you operate me or I'm not going to leave the hospital. He had been very insistent that he cannot live this quality of life. So we discussed and agreed to offer him surgery. It was a challenging case, and this is him after some time. The person who could not get up is now more independent and his life is changed. The next is early deep brain stimulation, whether you can offer this surgery earlier than 5 years, in very select cases between 4 and 5 years. But early deep brain stimulation is now considered, and this was possible because of this landmark paper which came out in New England Journal of Medicine in 2013, basis of which US FDA also approved deep brain stimulation in early Parkinson disease. And this paper was about 251 patients who were randomized equally between medical and surgical arm. Around 9 centers in Germany and 7 centers in France participated, and patients with early motor fluctuations had been recruited. So what they found was quality of life improved by 24% in surgical group versus worsening of quality of life in medical group. Similarly, UPDRS 3 scores, I told you motor disability scores improved by 53% in surgical group and only 1.2% in medical group. And levodopa reduction was by 40% in surgical group, whereas it increased in medical group. So overall, they concluded that neurostimulation in combination with medical therapy can therefore improve motor symptoms better than medical therapy alone at this early stage of disease also. In conclusion, we found that neurostimulation was superior to medical therapy alone at a relatively early stage of Parkinson's disease. So I would urge that don't wait too long, don't wait till the end of your disease. If you want to have a better quality of life, try to check with your doctor whether you are suitable for surgery if you are not happy with the current medical management. This was a gynecologist who had severe tremors, and obviously with that tremors in the right hand, no patient is going to get operated by him when any patient consults him. And he was just 53-year-old. So we offered him surgery, and you can see that he has been able to go back to his profession and perform surgery confidently. That is him performing surgery. And this we had been offering way early as 2004. This patient was operated in 2004. So he can confidently perform the surgery without any problem. That now two more parts of the talk that I need to talk about is the post-operative programming. I may give you the best devices. You may get surgery operated by the best surgeon. But if you do not know the post-operative management of these patients, which is very complex, because by now from Dr. Hu and Dr. Vadia's talk, you must have understood that this Parkinson's disease is not one symptom like fever or headache or backache. It's a complex of symptoms. And there are certain symptoms that can improve with medicine, certain symptoms that will improve with surgery, certain symptoms will worsen with medicine, certain symptoms will worsen with surgery, and there are certain symptoms you cannot do anything about. But then you need to be with those doctors and confident doctors who can guide you and take you through this journey, because it's a journey. You are going to get through this journey for several years in your life. So as I said, programming is an art, and unless you know this correctly, you would not be able to realize it. So better it is done by a clinician and people who have got experience of years and years of programming. I will show you this. This is a recent case that we operated, and it is a little technical, but you will see. The patient has become absolutely euphoric, aggressive, and his behavior has changed. We have put specialized lead called directional lead in him. I will be talking about that lead in a minute. But see, he has become very aggressive. His motor symptoms are well controlled, but his behavior has changed completely. So what we had done was we were stimulating this in a particular manner on the right and left side. I will not go into the technicalities of that, but when we modified these settings, because this particular device and directional lead give us possibility to modify this. And what was the modification? You can see that we have blocked the stimulation current on this side. On this side, there is no current. The red denotes current. So this is an electrode. So the electrode is delivering current in the front and two front electrodes, but the back electrodes is block the stimulation, which we thought was causing the side effect of his behavior. So then once we block that and we change the settings, you can see that now he is comfortably sitting, talking normally. This is the next day. So completely normal behavior. The last thing you want to know about the surgery is the risk factor of the surgery, because that is one thing that you need to be concerned about. As I said, at our center, we have been very much introspective. We do not want to depend on data which is available from outside, because this is something that depends upon the operator himself. So in 2011, we had published our review of long-term surgical and hardware complications of 150 cases. By 2021, we had completed 519 cases of analysis. Now we have operated more than 550 cases of deep brain stimulation, but we here reported 519 because this paper takes 6 months to get published. So this 519 cases over 20 years of experience was published. And what did that experience tell us? This is the most common complication that one should be worried about, or the most dreaded complication. I would not say common, it's the most fearful complication of DBS, and that is number of hemorrhages. You can see that post 200 cases, we become better. Till 200 cases, we also had declining number of hemorrhages, which are definitely acceptable. But post 200 cases, we were getting too well. And we had no hemorrhages in last several cases. Same thing is for the complications, number of surgeries. The number of complications kept on reducing, though they cannot become zero, because no surgeon can boast that he has a zero complication rate. He can only minimize the complication rate. So we, after this paper, we have concluded and we have recommended that any patient or any center who has to become a training center for any training grounds should have minimum experience of 200 deep brain stimulation surgery and should be doing more than 20 surgeries a year to qualify for training other people. Very quickly on the newer advances of the list, I talked to you about a segmented lead or directional leads that are new. These are fractionated lead, so you can block the current in one area and give the current in another area. The common leads are like this, cylindrical, where the current spreads symmetrically all around in a circumferential manner, whereas in a directional lead, you can block the current in one segment and then give it to another segment. So that is one about the leads. The second is the newer pacemakers. There are several pacemakers which have come, and different pacemakers have different capabilities and different limitations. Some are independent current source, then they are not MRI compatible. Some are whole body MRI compatible, but not having independent current source. There are some better charging pacemakers. Some are difficult to charge pacemakers. There are several permutations and combinations now available, which is, and we are fortunate that most of these are available in India as well now. And this is the future. Probably we will be going for tinier and tinier devices, and we may have this cranial mounted implantable neurostimulator at one point in time. The prototypes have been already made, and these are the prototypes, but still not available in the market. Several programming devices have been upgraded so that it helps the clinician to program the pacemaker better, and remote programming, though it's not available in US and Europe, in China it is available, in some parts of India it is available by Chinese company. But the international giants of neuromodulation, the St. Jude, Boston and Medtronic, have still not come up with remote programming because of some privacy and other challenges. The last part is the closed loop stimulation or sensing DBS. Now we have been talking about giving current empirically. So we are giving like 2 chapatis for, we think that 2 chapati will fill up stomach for every person. And we know that 2 chapatis are not enough. I need 4, someone needs 1, someone needs 3. How do you decide? So that is where this thought process came in. We can sample the signals from the brain, and depending on the disability of the signals or the record of the signal, we can deliver current into the brain. And that is what this group did, bilateral adaptive deep brain stimulation for Parkinson's disease. And they gave current only when the signals were of the brain signals or the Parkinson's signals were high. Once the signals became low with the medicines, the stimulation energy became low. So this is the amount of stimulation energy. So when medication effect started here, the amount of stimulation given to the brain was reduced. They found that they could prolong the battery life, they could reduce the side effect, and they can better control the efficacy of the DBS in this adaptive stimulation. We are likely to get these devices also in India very soon. With that, I would like to end this part of the talk with this particular slide. This is a beautiful dive of a kingfisher captured by Alan McFadden, a very eminent photographer, but it took him 72,000 shots to perfectly catch this dive. So these therapies are therapies of patience. You cannot say suddenly wake up one day and say that I am doing this and I am master on this. It is years and years of experience and hard work that can make you help build a good program and a good therapy. I will straight away move on to the next part of the talk, and that is going to be on the do's and don'ts of Parkinson's disease, DBS, which a lot of patients who have undergone DBS would like to know. And just give me a minute till I... Okay, so I'm going to rush into this a little faster. Basically, what are we concerned about? We are concerned about electromagnetic interference.
So we can still see your earlier slide.
Acha, sorry, let me just stop share and then, thank you. Okay, now the new one. Electromagnetic.
Yes.
Okay. So what is this electromagnetic interference? Is an interference created by electrical or magnetic field around the pacemaker because of various equipments found in environment. So what are the equipments which are safe and which are the equipment can cause interference to the pacemaker? Because this is a common question that the patient wants to know. Computer, cell phone, household appliances like microwave, oven, fridge, everything is normal. You can high voltage power lines, normal interaction unless you are directly exposed to that. Communication equipment, normal interaction, no problem. Probable interference is through the theft detectors, security gates, arc welders. These are the two common things: theft detectors and security gates at the airport and at the malls, and theft detectors, handheld theft detectors that you have to. And these are specific things which some personnel will be involved in: high voltage power lines, induction furnaces, and communicating equipment. We'll talk about MRI, CT scan, diathermy, dental procedure, lithotripsy, radiotherapy, and X-ray ultrasound. Which of them can be utilized and why they cannot be utilized, or how can they be utilized with patients in pacemaker? As I told you earlier, we have several implants now available in India. Some of them have different requirements, some of them have different requisite, and your doctor should be aware about it and they should be able to guide you. So for example, Activa PC is whole body MRI compatible. Versace Givia is also whole body MRI compatible. Versace is not compatible with MRI. So why are we concerned about MRI? There are three problems with MRI. One is the magnet can cause local heating at the level where the electrode is inserted in the brain, at the tissue and electrode interface. Second is magnetic field interaction. The magnet, because our pacemaker is also what magnetic computer parts. It's a computer programmable device. So the magnet can directly, strong magnet can directly influence on that, directly the pacemaker. And then there is an RF or induced stimulation. The radio frequency gradient, radio frequency field created by the magnet can actually alter the programming into the pacemaker and cause unwanted stimulation. So there are three reasons why this magnetic field can interfere. So should we do it or should we not? This is the guidance by the Medtronic group that you can do magnetic. It is compatible provided you keep specific absorption ratio to 0.1 watt per kilogram. Now you don't want to get into all these technical details because it is all difficult for you to understand. These are available on our website. This is available with the Medtronic website. This is available at all the standard doc with the doctors. But what we found was there was a study done by Nazaro, and they found that they went to a SAR value of 8 times than what was recommended by Medtronic, and they did not find any defect in 249 patients. So it is pretty safe. Not that that doesn't mean that tomorrow you can go ahead and go to the MRI center and get a MRI scan done. There are restrictions that applies and you need to follow that in connection with your doctor. Ludwig Zrinzo from Queen Square, London, also routinely performed MRI on all patients who had implanted DBS. So after the lead implantation, they had around 262 MRI scans that they evaluated. 15 of them had already got a pacemaker in place. They also had a good amount of SARS, 4 times the recommended dose, and they could not find any complication. What about 3 Tesla MRI? The new this were 1.5 Tesla MRI. If a stronger magnet is there, there have been one report in the literature which has showed that there is no adverse event in 102 cases. So reasonable safety is there, provided you have taken good precautions. The new Boston Scientific, I told you, the GVI device comes with a strong guideline, and they have a beautiful method so that the patient doesn't need to take the help of a clinician or the medical representative to switch off the pacemaker. In Medtronic, you will have to get someone to help you switch off the pacemaker. In Boston, there is a MRI enabling mode itself in the programmer. So when you switch that MRI enabling mode, automatically the pacemaker will reset all the parameters to make it safe for undergoing MRI. And they have, again, as I said, don't go into the detail. They have given guidance as to what are the requirements and what kind of limits that you can use while doing MRI. One important thing that you need to understand is that many patients with Medtronic devices earlier or Boston devices have got Medtronic implants, and vice versa. Medtronic patients with Medtronic leads have got Boston Scientific pacemaker. So they have mix and match pacemaker, basically. One company's lead, another company's pacemaker. Those cases, none of the companies allow you to undergo MRI because they don't want to take responsibility of these connectors. These are the connectors which are used to marry between these two different companies. It's a bridging connector which helps you connect to this device. So you cannot do an MRI when you have a connector. Again, guidelines are there, and which are the systems which are available, which are not, they are there. So Medtronic recommendation is check impedance, switch off the pacemaker if unipolar setting. If bipolar settings, you can continue on, but we always switch off the pacemaker. We do not want to take any chances. Do not perform the MRI if body temperature is more than 38 degrees centigrade. Do not cover with the blanket and do it in supine or prone position. Coming to surgical diathermy, there are two types of surgical diathermy. When surgeon operates, he uses an electrical cautery to achieve hemostasis. There are two types of cauteries. One is a cautery where there is a point of contact and the current spreads from there to the other part of the body through a ground plate. So that is supposed to be avoided. You can use a bipolar diathermy. And there are some principles for how to put that in place, that if you have to use unipolar diathermy, then use a grounding pad which is far away from the stimulator, use the lowest possible current, and other requirement. Another common problem that the patients would suffer is dental procedure. And what do we know about the dental procedure? There is a standard disclaimer from the company that you cannot use dental drills, but that is not fair because there have been several incidences people have used dental drills without any problem. This was a Japanese doctor group who found out that if you maintain this much distance, 6 centimeter from extension wire, 15 centimeter from lead, and 25 centimeter from patient programmer, and you limit the treatment time of the use of dental drill to 20 minutes, you are safe. How they reached that, we don't know, but this is a published paper, so I have quoted that. And electric motors found in dental handpieces, light curing units, endodontic heat carriers, apex locators, and electrosurgical units all generate some degree of EMI. Only electrosurgery unit produce EMI disturbance that may be possible. It's the same as the diathermy, but apart from that, you can use the drills safely. Same thing for another cardiac pacemaker. Suppose you have a cardiac pacemaker, can you implant a deep range stimulation pacemaker? Yes, you have to keep sufficient distance and you have to try to set the deep range stimulation in a bipolar mode. If you set it up in a unipolar mode, you will have to admit the patient to the ICU to observe for any interference and also try to keep it as far away from as possible. We had two patients. We had implanted a patient with DBS who already had a cardiac pacemaker, and then the DBS was in the abdominal wall. And then we had another patient who had to get cardiac pacemaker implanted. We had to move the DBS device away. So we had two patients and both of them had no problem. Suppose you get a heart stroke and you have to be, a defibrillator has to be used. Then there are some recommendation. Again, use the lowest possible current for the defibrillator, basically, and use the defibrillator as far away from the pacemaker as possible, and pedals should be perpendicular to the implanted device and not parallel to the implanted device. And same for the ECG, use ECG leads as far as away possible to avoid interference. And if it still gives interference and the ECG is not coming well, then you may actually switch off the ECG. Lithotripsy, kidney stone disease, and you have to use lithotripsy. Probably it's contraindicated, and in a nutshell, you should not use that. Same for high-end radiation therapy, cobalt and gamma radiation. If you have to use, if a patient suffers from cancer and he has to undergo this radiation therapy, which are more diffuse. Now we got very focused radiation therapy available, but if you have to use this diffuse radiation therapy, then probably you have to use lead shielding to cover that. And transcranial stimulation should be better avoided. We don't have any recommendation or guidelines for that. CT scan is absolutely safe. You can undergo CT scan without any problem. Theft detectors not allowed. I told you that you should not go through the theft detectors or handheld scanners. And activities which can put a significant amount of undue stress, like skydiving or scuba diving, should be restricted. And there are some recommendation by Medtronic, but other people have not given any major recommendation for that. Once the patient passes away, we in India cremate the patient most of the time. And before cremation, you need to explant the device because otherwise it will explode. It's a battery. So basically it will explode. So you have to get a doctor to come, open the chest wound here, and then you can just explant it. We give this kind of detailed information in a laminated sheet to all the patients undergoing deep brain stimulation at our center, so they can carry this and instruct the people under whom they will take care. And it is laminated so that it can stay for long with you. All these details are available on the website, so you can also check it out on this website. Do's and don'ts are there, so you can refer to it whenever you have any issues or concerns, or you can even dial into our center to ask for any guidance. With that, I would like to thank you for this talk, and we can take some questions in the end.
Firstly, Paresh, I think I need to thank you for the exhaustive list of all the precautions and do's and don'ts for DBS, because I mean, we spend a lot of time trying to answer these. So I think this was very, very useful. And I think this is a very useful presentation for all patients who have undergone deep brain stimulation.
Thank you. Yeah. So we have questions. Petros, you want to take this lead and take few questions which you think are pertinent?
Yeah. So I think we'll try to focus on those questions which are generic and not on individual treatment, because it's not possible to offer individual suggestions for their loved ones in a forum like this. I think one question is on a COVID vaccine, which is oft repeated question that I get every day. I think COVID vaccine is safe for all patients with Parkinson's disease. I mean, the same side effects as applicable to the general population apply. There's no specific Parkinson related risk. And definitely if you get COVID with Parkinson's, it really shifts the whole disease out of gear. So please, I would recommend, if you're eligible to take the vaccine, please take it. So I think, so there's one question on resistance to levodopa. Maybe we can ask Dr. Y to answer that. So does a patient become resistant to levodopa after years? And this is a very often repeated question. So I think it's important that we answer it.
Yeah, thank you for the question. Yeah, thank you, Dr. Doshi, for excellent presentation about DBS. So regarding the question, resistant to levodopa, yeah, this is a kind of a common question all over the world from the patients. As you know, usually levodopa works well in the beginning in the majority of patients. So carbidopa-levodopa can manage the symptoms of tremor, rigidity, bradycardia, slow movements. And over time, our major concern is motor fluctuation, and the patient have to levodopa in a short period of time.
Try to be a little louder. It's not very audible.
Oh, okay. So the medication can cause the carbidopa-levodopa can have the problem of motor fluctuation after long period of time of treatment. Motor fluctuation means that a patient have to take medication every 2 hours, 3 hours, or even every 1 hour. And in addition, patient might develop involuntary movements, dyskinesia, due to the medication of carbidopa-levodopa. So this kind of resistant problem can be managed by DBS, certainly. And so it's FDA approved for the treatment. And on the other hand, some patients question about resistance to levodopa means that levodopa has no benefits on the Parkinson disease symptom at all. So this subgroup is difficult to manage. And we think it's about 10% of Parkinson patients may have no response to Parkinson, the carbidopa-levodopa at all. But for the majority of patients who initially had a response to carbidopa-levodopa, then during the late time develop motor fluctuation disorder, and this group of patients can be managed with DBS for sure. On the other hand, some patients worry about the resistance to levodopa and delay the treatment. According to our the experience from our center, not necessary to delay the treatment of carbidopa-levodopa. And there's a study, and we also review Dr. Okun reviewed JAMA Neurology in 2020, addressed this question that patients should start carbidopa-levodopa if necessary because of the symptoms. And the benefits can last for a long time, for sure. And but later stage, if patient develop motor fluctuation, then they can alternative treatment. In meanwhile, exercise is important. Some exercise is also effective during the later stage of disease. Yeah, this is my answer. And I guess also regarding the inhaler medication, I think it's approved in India. Is that right, Dr. Wadia? Is the inhaler levodopa?
No, it's not approved in India. We don't have inhaled levodopa in India. And
Okay.
we don't have levodopa carbidopa intestinal gel either.
Okay, I see. I just need to address, I think somebody asked a question, but just need to address that it will cause cough. And if patient had a lung disease, any asthma, any respiratory issue, should not take this medication. But if it's not available in India, then it will be not a problem. Otherwise, I don't want a lot of patients to take a risk to have this medication. Yeah.
There is a question on nausea and Parkinson's. So nausea is seen because the medications for Parkinson more often than the disease really. And it's because the dopaminergic medication causes stimulation of the peripheral receptors outside the brain, and we need the dopamine inside the brain. So use of carbidopa, domperidone can really alleviate the nausea. And most of the times we do give that in the initial phase. So So there's a question on whether everybody goes through hallucinations. No, hallucinations occur in only about, thankfully, only about 15 to 20, 30% of the population. Again, depends on the severity of the disease, the drugs that are used. So thankfully, not everybody goes through hallucinations, but if they do, you need to bring that to your doctor's notice immediately. So I think there was a question about sleeping at night and somebody attacking. So sleeping at night when you're having abnormal behavior, you have to differentiate whether it's in sleep or whether it's just before you go to sleep. If it's in sleep, it's more likely the dream enactment behavior or REM sleep behavior disorder, which I mentioned in my lecture. While on the other hand, if you're having this hallucinations and you're awake, it could even be hallucinations where you're seeing things. So that needs to be a bit separated. So forgetfulness, I think you have to bring it to your doctor's notice. As I mentioned, there are medications which can be used, but there is a stepwise algorithm which I've shared in my slides. Okay, I think Dr. Doshi, you can take
I think there have been few general questions which has, as you rightly said, directly pertaining to people. There are people who wanted to contact Dr. Wadia. He can be contacted through Just Look Hospital, and probably Petrus, if you can type your phone number in the chat so they can contact if they want to directly contact you as well.
I'll do that.
Yeah, and I think I would like to also thank today two other members of the Parkinson Care Trust whom you have been interacting with. Is Miss Anulipa Nandi. Are you there, Anulipa? And Mrs. Bharti Karkera. Don't see them on the. Yes. A lot of people who have been coming to Just Look and seeing us and Petrus must have been knowing Mrs. Bharti Karkera, who has been with us for 20 years for Parkinson disease management now. And she's one of the most active workers in this field and helping patients. So this program would not have been possible unless the efforts put by her. And Anulipa, you are there? That is another name that you must be interacting with, whom you would be getting messages and SMSs from, and whom you would be interacting with your for the membership of Parkinson Care Trust. And she will be also, she is a part of our department, and she would also help you to answer your questions or connect with the patients and many other things. So she coordinates the activity of Parkinson Care Trust. And I once again would like to thank Dr. Wei Hu for taking out his time on a Saturday morning, a weekend, and sparing it to educate all the patients and caregivers of Parkinson's disease. And I think we all as a people working in this field feel one level of obligation nearer this period of the year, that is near the World Parkinson's Day, to do our bit of service that we can do to enhance the quality of life and improvement of caregivers. I would also like to thank Petrus for taking out his time and joining us and having an excellent talk. Both the talks of Dr. Hu and Dr. Wadia were superb and very enjoyable, and a lot of patients would have benefited from that. And the last important thing is that this webinars had been possible. We had a live webinar of physiotherapy and speech, which was actually done in the live in the auditorium, and that had been telecast. And all these things could not have been possible without the excellent support and help from Mr. Bhavesh Thakkar and Dr. Mansi, both of them who have been coordinating the webinar on the behalf of Chogle Medical Consult. And both of you, I would like to thank on behalf of Parkinson Care Trust and Just Look Hospital for standing with us and all this time. And with that, we would like to conclude this webinar, but we will be coming back to you in 2 months' time with a more specific webinar, which is again going to be based on patient-related requirements and patient activity. With that, once again, thanks everybody, and have a good weekend of whatever is left in India, and for US, the entire weekend. Okay, thank you.
Thank you very much. Bye-bye. Bye-bye.
Goodbye.
Thank you. Thank you. Bye-bye.